Good afternoon and welcome to our congressional briefing and national webinar on the report, Pain in the Nation, the Epidemics of Alcohol, Drug, and Suicide Deaths, hosted by Trust for America's Health, or TFAH for short. My name is Tim Hughes, the External Relations and Outreach Manager at TFAH. We would like to thank our speakers and audience for being with us today. Next slide, please. Great. Real-time captioning is provided today by Katie of AI Media. For captions, click on More on the bottom right of your Zoom screen and enable captions. Next, click on Close Caption. Next slide. ASL interpretation is also being provided today by Keystone Interpreting Solutions with Becky and Hannah as our interpreters. If you'd like to use ASL interpretation, hover your cursor over the interpretation button on the bottom of your Zoom screen. Next slide. We encourage you all to share your thoughts and questions about today's presentation by typing them in the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom on your screen. From there, select Enter when you are ready to submit your question. And as always, today's webinar is being recorded. That recording and slides will be available on TFAH's website by the end of this week, along with all the previous webinars we have held. And now it is my pleasure to introduce the moderator of today's event, Dr. Takesha Dwan Everett. Dr. Everett is TFAH's Executive Vice President. In this role, she works in partnerships with TFAH's President and CEO to chart and implement the organization's strategic directions and priorities, provides counsel on current and emerging policy issues, and engages with key organizations, policymakers, and other partners to advance policy priorities. Welcome, Dr. Everett.
Thank you, Tim. And thank you to everyone for joining us today for this important discussion. I want to welcome you, and hopefully you will find that this is an enjoyable and exciting opportunity to learn together and hear some really harrowing statistics, but also leave with some hope about what we can do to move our country forward. My name is Takesha Dwan Everett, as already mentioned, and I'm excited to be here today with our esteemed panelists. Our agenda today is on the slide, well, the next slide. And after our presentations, we will have time for discussion and questions from the audience. Before we get to our panel, I do want to start off with a brief recap of our 2024 Pain in the Nation report. A copy of the report is available online, and it includes state-specific information, and you can find that at www.tfah.org. We've also included a link in the chat. My hope for this briefing is that you will leave here with a better understanding of the comprehensive policies and programs that focus on the underlying causes of these deaths of despair to help heal individuals, communities, and make them more resilient. Next slide. Next slide. Hold on, it does seem that for some reason, maybe we're having a little bit of technical difficulty with our slides, so give us just a moment. And I'm looking for the next slide, where we begin some of the presentation data. I'll go ahead and move forward as we figure out what happens on the screen, and it'll catch up. The TFAH Pain in the Nation report series has tracked the nation's deaths of despair crisis since 2017. This latest report includes newly released data showing the 207,827 Americans who died due to alcohol, drugs, and suicide in 2022, which is a slight decline from the 2021 total. I'm going to pause for a second to see if we can get the graphic on for our slide, and I will welcome and introduce our panelists a little later. All right, I'm still not seeing it on my end, so I'll just keep going. Specifically in our report, we're noting that the alcohol-induced death rate has declined by 6% in 2022 compared with the 2021. And this is the first decline in this rate since 2002. In fact, the alcohol-induced death rate has doubled in the past 20 years. The drug overdose rate in 2022 was nearly identical to the rate in 2021 for a total of 107,941 deaths. This contrasts with 14 and 31% rates increases in the previous 2 years. Over the last 20 years, we've seen the overdose rate quadrupled. Finally, while the suicide rate has also remained unchanged from 2021 to 2022, it's important to note that the total annual suicides for 2022 matched the historic peak level from before the COVID-19 pandemic. The long-term trends in deaths due to alcohol overdose and suicide remain alarming, and of note, the 2022 rate is still more than double the rate compared to 20 years ago. More broadly, when we look at the combined deaths from alcohol overdose and suicide, we see a 142% increase between 2002 and 2022. Looking a little more closely at the 2022 data, there are a few notable variations by demographic groups that we want to highlight for you today. For example, white and Native Hawaiian and other Pacific Islander populations had modest decreases in drug overdose rates, while other populations saw increases, although they're not significant or as significant as they were or have been in recent years. In addition, for suicide and mortality, younger age groups saw decreases while mortality increased for overall older age groups. And for alcohol-induced deaths specifically, nearly all demographic and geographic groups experienced a decrease in the rate. Now, despite these improvements, our report makes clear that populations of color suffer disproportionate rates of substance misuse, often due to longstanding social and economic inequities like structural racism and community disinvestment. Death rates from overdoses and alcohol-induced causes in 2022 were among the highest among American Indian and Alaska Native people. And we also know that Black people experienced the second highest overdose rate of any racial or ethnic group in 2022. In terms of drug overdoses, illegal manufactured fentanyl continues to be the main driver of drug overdose deaths. And as of 2022, for example, synthetic opioids were connected to more than 2/3 of all fatal overdoses. Now, I want to take a moment and turn to our report's special feature. And our report's special feature highlights overdoses from synthetic opioids, primarily fentanyl, and notes that there has been an increase exponentially over the past decade, as well as looking at polysubstance overdoses involving multiple types of drugs, and that has increased as well. Cocaine, methamphetamines, alcohol, heroin, prescription opioids, benzodiazepines are commonly co-involved substances in these events. Among the drug types assessed in the 2024 CDC study, fatal synthetic opioid overdoses, and fatal opioid and stimulant overdoses had the greatest relative increases from 2010 to 2020. We've seen some prominent new kind of on the drugs on the scene, and specifically xylazine, a veterinary tranquilizer, has become a prominent additive in the illegal drug supply, especially in the Northeast. In addition to short-term effects like sedation, xylazine use is associated with serious wounds that in some cases can lead to infection, tissue death, and even limb loss. The pervasiveness of synthetic opioids in the illegal drug market, increasing polysubstance use, and and other evolving substance use patterns underscore the need for significant measures to reverse overdose trends. These measures include improving our data systems to track emerging trends, by geographic, demographic, and drug type metrics to guide local, state, and national responses, maximizing harm reduction strategies to save lives, including continuing to ensure access to naloxone, buprenorphine, and fentanyl test strips, improving treatments for drug overdoses and substance use disorders, including medications for stimulant overdose and stimulant use disorders, as well as increasing equitable access and eliminating barriers to current substance use disorder medications and treatments. Supporting and expanding the behavioral health workforce is important, including peer supports to reduce barriers and increase access to treatment and harm reduction measures. I want to assure to the listeners today that even though we've had a little bit of a challenge with our slide deck, this information is located in the report, and you can definitely access that report and see the trends that we're discussing, the graphics that we're mentioning, and all of the recommendations related to this in our report, Pain in the Nation, and you can find that at TFAH, www.tfa.org. Next slide. Americans struggling with substance use disorder or other behavioral health issues need urgent attention. We know the policies and programs that work to prevent deaths of despair, and we now need to invest in those programs. And our report includes a full list of recommendations that fall under 3 priorities. First, we should invest in prevention. By promoting policies and programs to address social and economic conditions that determine health outcomes, and reducing adverse child experiences and the impact of trauma, we know that Congress should should increase support for substance use prevention, mental health, and resiliency programs in schools. Second, we want to focus on the reduction, and we want to address the current drug use and overdose crisis by supporting safe storage of medications and firearms and other limits on access to lethal means, as well as harm reduction policies to reduce overdoses and infections. State and local governments can also address rising rates of alcohol-related deaths by increasing pricing, reducing sales hours, and limiting the density of alcohol outlets. Finally, we should transform the mental health and substance use prevention treatment systems. We can do this by bolstering the continuum of crisis intervention, including the 988 Lifeline, promote equity through culturally and linguistically appropriate services to reduce disparities in outcomes, and expand the mental health and substance use treatment workforce, including through peer support specialists. We ask Congress to support efforts to expand access to care and modernize services by integrating mental health and physical health care. Now that we've had this overview of our report and the stark trends and those timely recommendations in mind, I am so excited to introduce our esteemed panel. We want to remind you that you'll have an opportunity to ask questions, but we're going to go through our panelist discussions after the introductions, and I'm so thrilled to be joined by Dr. Allison Arwady, who is the director of the National Center for Injury Prevention and Control, where she leads CDC's innovative research and science-based programs to prevent injuries and violence and to reduce their consequences. Dr. Arwady previously served as the commissioner of the Chicago Department of Public Health, leading the health department of the nation's 3rd largest city, including through the COVID-19 pandemic. We're also joined today by Captain Christopher Jones, who is the director of the Center for Substance Abuse Prevention. Captain Jones brings a wealth of experience to SAMHSA, having led substance use, mental health, and injury and violence prevention policy, program, and research activities for more than a decade. And prior to becoming the director of CSAP, Captain Jones served as the director of the National Center for Injury Prevention and Control at the Centers for the Centers of Disease Control and Prevention. I shorthanded that there. And our final panelist joining us this afternoon is Dr. Alex Crosby, who was raised in Detroit, Michigan. He is the son of Emerald and Corinne Crosby and is the father of 4 wonderful children. He graduated from Fisk University with a bachelor's in chemistry, and he received his medical degree from Howard University's College of Medicine and his MPH in Health Administration and Management from Emory School of Public Health. He's completed training in family medicine and general preventive medicine and public health and epidemiology. He worked at the CDC for over 30 years and has an immense amount of background, including having authored and co-authored over 125 publications related to addressing suicide clusters, civil unrest, school-associated violence, sniper attacks, and the list goes on. I would love to welcome now and turn over the virtual mic to Dr. Arwady.
Thanks so much, Dr. Everett. Really looking forward to hearing what all the panelists have to say. I want to congratulate TFAH on the release of this important report, and thank you just for the continued collaboration in this critical space. We know that making progress on these topics especially requires coalitions, requires making sure that we are coming together to bring expertise, to listen to communities, to make sure we're using data. But I do believe that we can make progress on these topics. Go ahead to my next slide. Okay, perfect. So today, as is highlighted in this report, one of the things I really like about it is that it's highlighting how interconnected some of these challenges are. Today, I'll just be highlighting very, very quickly some of the work that CDC is doing on advancing overdose, suicide, and ACEs, or adverse childhood experiences prevention. These share a lot of the same risk factors. They are largely preventable. And when we are making progress on one, if we're careful about it, we can make progress on all three of these together. For example, if we are making investments in protecting and strengthening household financial security, that is something that may be a strategy specifically related to comprehensive suicide prevention, but it can also prevent violence. It can prevent ACEs. It can prevent substance use. And so, one of the reasons I do this work, you heard I'm a doctor and I'm at CDC. I spent a long time working at the state and local level. And I believe so strongly that these topics can be moved with the same public health approaches that we've taken to addressing infectious diseases over the last century. So if you can move ahead, please. I just want to highlight that, again, at the Injury Center, that's the center that I'm leading at CDC, we are all about putting science and data into action. Our priority topics here are preventing overdose, preventing suicide, preventing violence across the lifespan, and linking all of that together with the work on preventing adverse childhood experiences. In case you're not familiar, those are experiences that happen, children under 18 who are witnessing or directly experiencing abuse, violence, neglect, or they're growing up in households that are not stable because, for example, a parent or guardian has an untreated mental health condition or an untreated substance use disorder. And we know that preventing ACEs has an outside positive effect as children turn into adults. Just as one example, if we were able to prevent as a society all adverse childhood experiences, we predict that we would reduce the example or the incidence of adult depression diagnoses by 44%. And when you think about these crises, the ability to work upstream and think about prevention while we continue to strengthen treatment is critical. Next slide. All right, so this is a slide. I just want to show you one data slide about a little bit of the history of looking at deaths in the first half of life. So the Injury Center focuses on the leading causes of death for ages 1 to 44. You're going to see here, right on the slide, this is what it looked like in 1981. Unintentional injuries, we had the most deaths from there, and that does include unintentional poisonings and drug overdoses. It includes motor vehicle fatalities, drownings, and falls. You'll see the rest of the list coming down here. Cancer in orange is homicide, heart disease, green is suicide, and so on. So if you can play this, we're going to move forward in time, and you're going to see that top bar, there we go, remains at the top. We're going to start seeing, as the 80s go on here comes HIV moving up, starts to become really one of the leading causes of death, gets all the way to number 2, never quite beats out injury. But as we move into the 90s, we're able to get treatments for HIV, and that drops back down in a beautiful way. We start making some real progress on cancer, especially as we get into the 2000s, and we're going to see that start to drop a little bit. And we start seeing suicide move up as we move into 2010. But then as we hit the mid 2000s and fentanyl starts to get on the scene, we see this huge increase in unintentional injuries. And as COVID hits, we see an even bigger increase, most of that being driven by drug overdose. And as we get to 2022, which is the last year with the official data, unintentional injury is still way outpacing the other causes here. But suicide is number 2 and homicide is number 3. And so one of the reasons that it's so critical that we all work together on these topics is that these are the leading causes of death for the first half of life, and they are some of the leading causes of death for older Americans as well. Move ahead, please. Yeah, to the next slide. Thank you. So what is some of what we do in this space, just in a very quick overview? So the National Center for Injury Prevention and Control puts a lot of focus, as does the rest of CDC, in supporting work in the field. Between 80 and 85% of our budget, depending on the grant opportunity that comes from Congress to CDC, is going right back out the door. We primarily are funding state health departments, local health departments, their partners, just to give you a very high level sense of some of the primary funding opportunities here. Our largest grant is called Overdose Data to Action. You can see it's getting close to $300 million that's going to state and local health departments to ensure we are building the data infrastructure to stay ahead of the overdose crisis, as well as turning that data into evidence-based action on the ground. Our comprehensive suicide prevention program, you can see the dollar amount there. This point is in 24 states. It's been a rapidly growing program. Again, building the infrastructure to make sure that we're not just counting completed suicides, but we have a much better real-time data source of where we're seeing trends in people thinking about suicide or potentially with suicide attempts coming into emergency departments. We want to capture that very, very quickly and then be able to take action on the ground to help keep those numbers down. We have a specific line for tribal suicide prevention. Some of the most creative and innovative work, I think, in the country is happening around tribal suicide prevention work because American Indian and Alaska Native populations still bearing a huge brunt disproportionately in terms of suicide outcomes. And then finally, I wanted to highlight that we do even have some grants for preventing adverse childhood experiences, again, with a data to action framework. You can see the funding amount there. That's just across 13 states. If you move ahead to the next slide. The TFAH's report, the Pain in the Nation report, draws some extra attention to polysubstance use and to some emerging drug overdose trends. And so I just wanted to give a little flavor of what we've been seeing recently. So one thing we've been working on as an agency is making our data more timely. Overdose death fatalities can take over a year to get the final reports back from coroners and medical examiners around the country. They can take a long time to investigate. We're often waiting for toxicology or specialized toxicology reports, but we don't want to just look at what was happening a year ago or 2 years ago. And so we've been working with states and jurisdictions to have some provisional data available based on some predictive modeling, but really being able to have a sense with just about a 4-month lag of where we are going as a country. So I want to emphasize that these numbers are predicted and provisional. They will change a little bit as the year goes on. We release final data at the end of each calendar year. But 2023 marked the first time as a country that we were down 3% in overdose deaths compared to the prior year after so many years of increase, like I showed you in that graph at the beginning. And this was data just released in the early September from 4 months ago, showing that the most recent 12-month period, we had just over 101,000 deaths across the country. That is way too many. That is still 1 death every 5 to 6 minutes, but it's down from 111,000 the 12 months, ending in April the year before, and that would be about a 10% change. I don't know where we will end at the end of this year, but I do want to highlight that all of those states in blue we're seeing a decrease during that 12-month period. Out west, we still have some states, though, where illicitly made fentanyl in particular has gotten there later, that is still working to get on top of this. We see a lot of regional variation, and that's part of why it's so important that we have up-to-date data that is local and actionable and timely to make sure that all over the country, we want this whole map to be blue and we want it to stay blue. But some signs of hope here for sure in terms of turning the corner on this crisis. Next slide, please. I also just wanted to put a little bit of data in front of you about the crisis. It's not really just an opioid crisis at this point. It really is about polysubstance use. The fact that many of our deaths now include opioids and other substances, and particularly that includes stimulants, right? Illegal drugs are stimulants, things like methamphetamine or cocaine or ecstasy. We do also have prescription stimulants. People may take those for ADHD or depression even. And although the prescriptions are less likely to be, the prescription stimulants less likely to be direct causes of overdose, we do see misuse patterns sometimes in them, and certainly there is an overlap. So this is the data from all of 2023 last year, and across the 30 jurisdictions at this point that have really robust data on this, we're growing that number every year. You can see that nearly half on the left there in blue, the largest category, those deaths were in people who had both opioids and stimulants in their system at the time that they had their fatal overdose. And that really is a dramatic increase. If you look back just, as recently as 2010, we were seeing rates, maybe 25% of this. We've seen increases in that use with both opioids and stimulants together go up 300, 400% just over the last decade and a half. And so when we are thinking about responses here, whether that's education, whether that's data, whether that's involvement across all sectors, it is important. Illicitly manufactured fentanyl remains the leading substance that we are identifying for both overdose fatalities and overdoses that are not fatal, but it's important that we think about how these are fitting together. Next slide. I also just want to highlight that the crisis is changing in other ways. We have a system called our State Unintentional Drug Overdose Report System, which is about fatal drug overdoses around the country, collecting more than 600 data elements from death certificates, from medical examiner reports, from toxicology reports, really trying to pull together, as you can see, let's not just count, let's make sure we understand the circumstances, the comorbidities, the contributing drugs. And just in the last few months, we've shared, for example, we're seeing some changing modes of drug use. For years, injection drug use was the leading modality when we would see fatal overdoses. That has now shifted, and smoking is actually now the leading modality that we're documenting around fatal overdoses, although we need to continue to work on the injection drug use. We're seeing an increased percentage of overdose deaths linked to counterfeit pills, and then we're seeing the emergence and the reemergence of some drug threats like xylazine, which was mentioned. Even carfentanil is back on the rise. And so it's just critical that we've got the data systems to stay on top of this. Next slide. So just to wrap this up, I want to point you to some of the CDC's resources for action. Across all of our topic areas, the scientists at CDC are working to make sure we're keeping the evidence up to date for folks who are working on adverse childhood experiences prevention or suicide or overdose. We keep track of the latest research. We look across the country at what is working best, what is not working best. And if you are interested in learning more, I will refer you to the QR codes there. But this is what states and communities, especially through health departments, which is who CDC is most traditionally funding and supporting, are using as they turn their data into action. And so finally, last slide there, I do just want to say thank you, focusing on preventing overdose and suicide and ACEs and violence. This is work we do together, and these are the crises still that are killing the most people in the first half of life in this country. So thanks for the opportunity to share. Looking forward to the other panelists, and appreciate all of your interest and all of the work that you are doing on these critical topics. Thanks.
Thank you so much, Dr. Already. And next, we will hear from Captain Jones from SAMHSA. And I just want to welcome you now to the virtual mic. Thank you.
Great. Thank you so much, Dr. Everett and Dr. Awady. Always good to be with you, hearing about CDC's work. Next slide, please. Next slide. So building on some of the prior presentation from CDC, I just want to set the stage a little bit as we're thinking about our substance use prevention work at SAMHSA. And I think one thing that we don't talk about enough is the fact that we have been making progress depending on which outcomes that you're looking at. But when we look at past year use of substances among youth, we see that we're at historically low levels of substance use. This figure is from the Monitoring the Future study, which is funded by NIH each year. But CDC's Youth Risk Behavior Survey, which released its top line numbers about a month or so ago, also showed continuing declines in youth substance use. So we are making progress, but when we look at the outcomes like overdose and suicide, obviously, as highlighted in the TFAH report, we have a long ways to go and certainly many opportunities to make progress. But it's important to know that we want to continue to build on the gains that we are seeing, whether it is stabilizing suicide or slightly declined overdose deaths, slightly declined alcohol-induced deaths, but also building on these root drivers and progress that we've made in reducing substance use. And as we think about how we do our work, we've really been trying to work with our partners in communities and in the field to say that we have to do both things. We have to address the acute urgency of overdose while also remaining laser focused on the root drivers and the upstream side of the prevention work. And that's the balance that we're trying to strike in our work in CSAP. Next slide. It's also important to note that as rightly pointed out in TFAH's report, that substance use doesn't happen in a vacuum. This is looking specifically at youth substance use. We see from the National Survey on Drug Use and Health among 12 to 17-year-olds that youth who are using marijuana are also using nicotine, using alcohol, using other substances. So polysubstance use is really the norm, not the exception. We also see that substance use is intimately linked to mental health challenges. And when you look at youth with a major depressive episode in the past year, we see higher rates of substance use across all substances that we examine. And then the CDC YRBS data really underscores the point that youth are experiencing other challenges that are also linked to substance use, like not feeling safe at school, experiencing sexual violence, other forms of violence, bullying, electronic bullying, experiencing poor mental health, persistent feelings of sadness and hopelessness. So we have to take a comprehensive approach as we are addressing these issues. So it's not just that we're going to focus on one particular area, but we're going to look at the individual, the family, the community, the school, and the society context as we think about our prevention work. Next slide. The other point that I think is really important to point out, because a lot of resources that have come to communities in recent years have been focused on the downstream side of this, expanding access to treatment, expanding access to naloxone and other opioid overdose reversal medications. And those things are absolutely needed, given the urgency and the magnitude of the crisis. But we see that the vast majority of people who report using substances in the past year don't have a substance use disorder. So they are at risk for harms related to their substance use and certainly at risk for progressing to a substance use disorder. But there are many more people who could benefit from preventive interventions, often than we have the actual resources to support coverage in communities. Next slide. And I just think it's so important to underscore that the prevention work has never been more important. This is from a paper that we did in collaboration with CDC and NIH a couple of months ago to document really the multi-generational impacts of the overdose crisis, recognizing that over 320,000 kids across the country are estimated to have lost a parent to drug overdose over a decade period through 2021. And this is very much connected into social, economic, and other stressors that are playing out in homes and communities. And if we don't address this in a holistic way, we're going to continue having to play catch up with the crisis that we're experiencing. Next slide. Next slide. And in CSAP, our work is guided by two overarching frameworks. First, the overdose prevention strategy from the U.S. Department of Health and Human Services, which includes primary prevention, harm reduction, treatment, and recovery support. And then from SAMHSA's strategic plan, really pillars 1 and 3, preventing substance use and overdose, and then promoting resilience and emotional health for children, youth, and families. Next slide. And I've been in the CSAP role for a little over a year. And one of the first things that I did when I came to the center was really try to focus in on who are we? Who are we as a center, and how do we want to help move the substance use prevention field forward? And we landed on a vision that is really substance agnostic. It's really, what do we want to see play out in communities? And that's really where individuals, families, and communities are healthy and thriving. We're focused on preventing the initiation of substance use, preventing the progression, and preventing and reducing substance use-related harms. And we do this in 4 primary ways. We want to analyze the data and help people understand what are the latest trends and what works in prevention, building prevention capacity at all levels through funding, training, technical assistance, advancing prevention through strategic partnerships and collaborations, and then ultimately using our voice to catalyze prevention action in communities. And we have a set of guiding principles that infuse throughout our work. Next slide. And as we think about prevention, often prevention is focused on youth because substance use, mental health challenges, suicide risk are often first emerging in adolescence. And we see that there is certainly an opportunity for prevention because the vast majority of young people are not using substances. So we have an opportunity to decrease initiation of substances. But we see that that very quickly drops by the time people turn 18 to 25, as you can see on the first part of this figure. But even when we look at initiation of the 3 most commonly used substances, nicotine, alcohol, and cannabis, there are many adults who are initiating use of those substances for the first time. So we do have to think about prevention across the lifespan and think about strategies that are certainly age appropriate and context specific, but there are opportunities prevention not only among young people. Next slide. And as was mentioned, from the CDC presentation, there are certainly opportunities in the overdose prevention space, but even on the broader youth prevention, we see that many young people are not exposed to evidence-based prevention programming messages, whether it's in the school or in the community. So we have an opportunity to scale up those evidence-based strategies. And in the case of overdose, based on CDC's Suitors data, which Dr. already talked about, we see that there are many missed opportunities for overdose prevention and response as well. Even when somebody might be in the home or a bystander is present, naloxone is not used certainly as much as we would want it to be to save a life in an acute overdose situation. Next slide. So we're taking a holistic approach on this. And again, this follows, sort of public health 101, how we think about where are the levers for prevention at the individual level, relationship, community, and societal level. There are opportunities, whether it's programs, policies, or practices, to look at the drivers in communities of risk. What are the things that we can do to bolster protective factors to drive down substance use and related harms? And ultimately, the flip side of that is building individual, family, and community resilience. Next slide. And we are doing this through our programmatic work. And most of our funding goes to state substance use agencies, at least our bigger funding, like our block grant for substance use prevention, treatment, and recovery services. From the prevention side is the biggest prevention investment in HHS focused on primary prevention. We also have a variety of discretionary programs. Some of those focus on underage drinking, like our Stop Act program, and some of them are really building prevention capacity at both the community, tribal, jurisdiction, and state level, like our Strategic Prevention Framework Partnership for Success program. And then we have more targeted programs that focus on expanding access to opioid overdose reversal medications, overdose prevention and response training, whether that be focused on first responders, other community sectors, or the healthcare sector. Next slide. And then the last thing is just using that voice to catalyze prevention action. We have a national media campaign called Talk They Hear You. It's been around for over a decade, really focused on parents, adults, other influencers of young people, helping to provide public service announcements, other starter kits on how to have that conversation with kids, how to build connection with kids to talk about risk of substance use in their lives. We have a mobile app called Screen for Success, which allows people to take a very short screener to support conversations about well-being and overall health and identify resources that might be needed for individuals. And then we work through a variety of partnerships to really embrace youth empowerment opportunities and leadership opportunities for young people. We recently held a youth summit just a couple of weeks ago where we brought youth from across the country together to really empower them and provide feedback for how can we advance our prevention work at SAMHSA, really embracing the ideas of youth and the voices of youth in that work. And this is really critical to informing our efforts moving forward, because we want to make sure that the things we are doing are resonant and salient to the audiences in which we are trying to reach. Next slide. So once again, just want to say thank you to TFAH, to Dr. Everett and others for the opportunity to be here. I really appreciate the partnership, but also the partnership with CDC and other HHS agencies. These are complex issues, and it takes all of us working together, pulling all of the levers that we have in the substance use space, in the public health space, in the medical space, in other spaces to really make an impact, the impact that we want to see in communities. So thank you very much.
Thank you so much, Captain Jones, and you're correct, it takes all of us. And as we go to our final panelist, I am so excited that we'll get a chance to hear from Dr. Crosby from the Morehouse School of Medicine. And as a reminder, we want you to put your questions for the panel in the Q&A feature. We'll be going to those shortly, but welcome, Dr. Crosby.
Thank you very much. Good afternoon to all of you, to those especially on the East Coast. I guess it may be still morning for those of you farther out west. And also thank the Trust for America's Health for the invitation to come and to present to you. I'm going to talk about the patterns and prevention of suicidal behavior among African Americans, among American Indians, Alaska Natives, and a little bit among youth in general. Oftentimes when people think about some of the health issues that face minoritized communities, they oftentimes think of some of the leading causes of death overall, which might be things like cancer and heart disease and HIV, but oftentimes forget about things like suicidal behavior. But they are important, and we'll see, and we'll talk a little bit more about what's going on in regards to some of the data, as well as some of the prevention activities for those particular issues, suicidal behavior, mental health. I'll talk a little bit about the public health approach, kind of how that is set up and what that looks like in terms of the organization, and then apply that to suicidal behavior. And you will hear some things that are very similar to what Dr. Jones and Dr. Arwady just mentioned, but I'll repeat a few things and elaborate a little bit on them. Next slide, please. So here's the public health approach. You can see in the green, assessing the problem, kind of figuring out what the who, what, when, where of any particular issue is, and then moving into the orange, which is the why. If we can understand the risk and protective factors for any particular issue, we ought to be able to take that why and then move towards that light blue. What do we now take in terms of understanding the risk factors, understanding the protective factors, and developing programs and policies, trying to figure out what works, also what doesn't work, and then take that information and kind of moving to the purple, which is implementation and dissemination. Can we now take what we know from understanding about the trends, understanding which communities are at risk, what the why is, and then also the programs and policies, and spread that information. And oftentimes in public health, we are doing all four of those things as we learn more, as we get better at what those programs are, that we're revising them, we're refining them, and we're doing more as we continue to improve what it is that we're trying to do to address the problem. We can go to the next slide. Suicidal behavior, as you've heard, is the 11th leading cause of death in the United States, according to the most recent full data that we have. But the 11th leading cause overall may mask a little bit about what we know about suicidal behavior among different age groups. And here you can see from the age groups of 10 to 14, 15 to 19, 20 to 29, 30 to 39. So especially among adolescents, even pre-adolescents up through young adults, suicide is the second or the third leading cause of death. So it disproportionately affects young people in the United States. Move on to the next slide. This is just to give a demonstration of kind of what's happened with suicidal behavior over the past 23 years in the United States, and just to demonstrate that it's not just one community that's at risk for suicidal behavior. Here you can see on the left side, suicide rates among males by race and ethnic groups. You can see looking at non-Hispanic whites, non-Hispanic blacks, Hispanics, non-Hispanic Asian Pacific Islanders, and then non-Hispanic American Indians, Alaska Natives among males. every group has gone up. I think the one group where it was not statistically significant was Asian Pacific Islanders, but every other group is increased among males. When you go and shift over and look on the right side among females, unfortunately, very similar pattern. Non-Hispanic whites increase, non-Hispanic blacks increase, Hispanics increase, non-Hispanic Asian Pacific Islanders increase, non-Hispanic Asian American Indian and Alaska Natives increase. So among males and females, regardless of which racial and ethnic group you're talking about, rates have increased. And actually, back a few years ago when CDC looked at it, while the rate magnitude is different between males and females, what they found is that the increase was going up faster among females. Next slide, please. This graph just kind of gives you an illustration of where in the various populations you can see some of the issues regarding where the rates are highest among different populations. The American Indian, Alaskan Native graph is showing very high rates among adolescents and young adults, whereas if you compare that with white non-Hispanics, high rates among middle age, 40s, 50s, 60s. So again, as we're understanding what the patterns are, it helps us in terms of thinking about what those prevention programs, where we might focus the intervention, which age groups, which populations. This is also helpful in terms of us understanding the data and putting that data to use. Next slide, please. Among African Americans aged 10 to 34, one of the things you may note about this particular slide is especially when you look at those adolescents and young adults from about the mid-2000s, about 2014 on up to 2022, steady increases in population. What this slide does not show, and one of the things that the Congressional Black Caucus was very interested in, is especially suicide rates among preteen African Americans, that they have increased fairly dramatically. And while the numbers are still fairly small, it's one of those issues for which we don't want to wait until there's a catastrophe, right? Until there's a crisis. But if we can notice what's happening in regards to the rates among those young African Americans, then we can start to do interventions, start to do programs to try to address the suicides among that particular age group. Next slide, please. Deaths are just one piece of what's going on in regards to the burden of suicidal behavior and self-directed violence. This is just giving you an example among those aged 14 to 25, that deaths, several thousand, just under 7,000. But when you look at hospitalizations, 55,000, over 200,000 emergency department visits, over 2 million self-reported suicide attempts among this age group, and then over 7 million say that they've seriously considered suicide in the past 12 months. Part of what this slide shows us is the burden is not just among deaths. We want to prevent deaths, but it also gives us an idea, actually, if you flip this pyramid around, that there are 7 million adolescents and young adults that say that they've seriously considered suicide. This is a point in which we might look at intervention. Can we prevent those 7 million or those 2 million that self-report a suicide attempt? Can we prevent them from having a fatal outcome in regards to suicidal behavior? And I think we can. We've talked about some of the prevention programs, but here's an idea in which we can take what we know about those populations that are at risk, identify them, and get them into the right kind of intervention. Next slide, please. This is from the Youth Risk Behavior Survey. You've heard a little bit about this already, but you can see here where females, as part of looking at self-directed violence and especially suicide attempts, report more than males. And you can see two of the groups that report the highest burden of suicide attempts: African American, non-Hispanics, the second one from the left, and then American Indians and Alaskan Natives. Next slide, please. Also, as part of that Youth Risk Behavior Survey, where we can look at groups that may be at risk, when they ask about sexual identity and sexual orientation, those that report either bisexual or same-sex interaction report many more suicide attempts and suicidal thoughts and suicidal behavior. Next slide. Move on to the next slide. just as you saw what Captain Jones had demonstrated, the social ecological model gives us some ideas about where those risk factors and those protective factors exist that we might focus our programs, whether it's at the individual level, at the relationship level, which is oftentimes family and peer group, at the community level, or at the societal level. This also gives us a place for which we can say, okay, if we've got a program that might be able to focus on connectedness, a relationship issue, whether that's within the family or within a social connectedness, that may be a place in which we can be effective in terms of the prevention programs. Next slide. This is just to give you an example that for most part, when we talk about those that are at risk for suicidal behavior, those that are at risk for a number of different, whether it's substance abuse, whether it's alcohol, whether it's overdose, that oftentimes they don't exist in isolation. Here's a child in which you've got housing insecurity, you've got food insecurity, you've got physical illness, and all of those can interact to put this child or to put those adolescents or to put those young adults at risk for suicidal behavior. Next slide. And the next one. So we'll talk a little bit about what are some of the prevention programs here. You've heard a little bit about talking about upstream, and I'll just give you kind of an illustration. If you look over on the right side, you can see people walking over the bridge. There's a hole in the bridge. They can fall through that hole into the river. If we can prevent them from falling into the river, if we can patch up that bridge, we can stop that in terms of primary prevention. Once they fall into the river at risk for drowning, looks like if you follow where that river is going along, they can grab a hold of some of the rocks. We can throw a lifesaver out to them and try to pull them over to the side. That takes a little bit more resources. That takes a little bit more energy, a little bit more skill. If they slip off the rocks and keep on floating down the river, you can see they're coming towards the waterfall. At that point, it takes a lot more skill, a lot more resources, a lot more personnel in order to try to reach them. In that point, we got to get in the boat, get out into the river and pull them back in over to the shore. So if we look at down across the bottom of the slide, here are some of the places where some of these interventions, and in public health, we're doing some in all three of those stages, but we realize to be the most effective and to be the most efficient, we want to focus on trying to do more primary prevention. Next slide, please. One of the things that CDC did, and we can actually go on to the next slide, as you've heard a little bit about the resources for action, they identified 7 different strategies that were the best available evidence. And I know that SAMHSA has also been doing some work in terms of a registry for evidence-based programs. Here are some of the different kinds of programs that had the best available evidence. One of the things just to point out, not any specific interventions, but when you look at this, many of them do not say anything about suicide prevention. They're talking about strengthening household financial security, housing stabilization, promoting coping and resiliency skills. So again, some of the things that we've talked about that go across various types of adverse outcomes: overdose, alcohol, substance abuse, suicidal behavior. All of those can be impacted by some of these different kinds of strategies. Next slide. And going on to the next one. One of the things that has occurred released just earlier part of this year in April was the National Strategy for Suicide Prevention. This is the 3rd iteration of it. Part of what the benefit of that national strategy is a national collaboration between multiple agencies, but it gives states as well as local communities and local health departments a map and gives them a template for how to develop their own strategy, a state strategy or a county strategy, has goals and objectives, also has some action plans developed from each of the operational divisions within Department of Health and Human Services. So what is CDC going to do to carry out some aspects of that national strategy? What is SAMHSA going to do? What is NIH going to do? And this also can give a plan for what other organizations can do that are not federal agencies, but what can you do to take a look at pieces of a strategy and carry those out in regards to suicide prevention? Next slide. So in conclusion, suicide is a significant public health problem, disproportionately affects young people, results from an interaction of various factors, never one particular thing that causes suicidal behavior, but it also gives us multiple opportunities for intervention. Research has shown that much of suicidal behavior can be prevented. We have seen in certain communities, in certain places where they've implemented comprehensive suicide prevention and dropped suicide rates by 40 to 50%. There's a broad responsibility for addressing the issue. And I think, as Captain Jones pointed out, that it's a multi-sectoral issue. That when we think of suicidal behavior as a societal problem, that means we're talking about public health being involved, the clinical community being involved, social services being involved, the schools being involved, the faith-based organizations being involved, criminal justice being involved, the business community being involved. All of them have a role to play. All of them have tools and skills and resources to bring to bear on this particular issue, and all of us can make a difference. So I've talked about the public health approach, shown how we can apply that public health approach to suicidal prevention. Next slide. Thank you very much for your attention.
Thank you, Dr. Crosby, and thank you to all of the panelists. This has been an amazing conversation where I've seen a lot of through points through what each of you have said that leads us down to the road of prevention is key, targeted interventions are important, and collective action that we see across all of our institutions, our organizations, and governmental public health is definitely necessary. We're going to open it up now for Q&A, and as a reminder, you can submit your questions through the Q&A feature, but I'm happy to be joined by my colleague, Brandon Revis, who is the Senior Government Relations Manager at TFAH, who will help moderate the Q&A portion. So Brandon, take it away.
Thank you, Dr. Everett. Our first question from the audience asks Dr. Arwady, any advice to states looking to use opioid settlement monies on prevention programs? Kentucky just approved $3.6 million for a youth drug prevention initiative. And should some of this money be used for adult prevention, not just on youth?
Yeah, great question. I think the conversation around the opioid settlement dollars is one of the most exciting and challenging conversations happening in every state right now. I love the question because I am hearing sort of the state that the question is coming from is making a decision to invest in prevention and to invest in public health approaches. And I think, we've seen the through line through all of these presentations today that the need to do that is really critical, that we're not going to treat our way out of the opioid crisis one patient at a time. And though we need to continue to build the treatment infrastructure and get folks connected, I think opioid settlement decisions that make some of those investments in prevention in a data-supported and evidence-supported kind of way are making some good decisions. Certainly would refer you or anybody who's thinking about opioid settlements to some of the resources that we've shared on the call today. Certainly from the CDC standpoint, if someone is connected to a health department and wants to talk offline about ways to be involved in opioid settlement conversations in that state, we'd be happy to have that conversation. But a good opioid settlement approach, I think, takes a multi-sectoral approach, just like we heard from Dr. Crosby there. So happy to take a specific conversation offline, but I think by and large, the fact that you're even asking the question about how do we make sure prevention is in there and how do we think beyond youth tells me you're thinking in the right place and really pushing your state to use those dollars in the ways that are going to be most effective long-term.
Thank you, Dr. Arwady. We have time for one more quick question and answer. And our audience member asks, Captain Jones, when we are thinking of culturally and linguistically relevant resources and programs for youth, what innovative intersectional programs and partnerships, i.e. those addressing SUD and suicide simultaneously, exist between private and public partners, and what is possible in this space?
Yeah, it's a great question. I can say as one programmatic example, we have a braided program with our Center for Mental Health Services focused on tribal communities, our tribal behavioral health program, which is by design focused on the shared risk and protective factors around substance use, suicide, mental health in tribal communities, as was well documented. They have the highest rates for overdose, for suicide. Certainly multi-generational trauma and social determinants are at play there as well, and high rates of adverse childhood experiences. So that program, we really have tried to work with tribes to be culturally informed in those efforts. We focus sort of on culture as prevention, traditional practices, community-defined evidence, in addition to the evidence-based strategies, recognizing that the evidence base wasn't necessarily built in tribal populations. So it may not apply 100%, but it could potentially be adapted, or it has a conceptual underpinning, which could be embraced and tailored to meet needs of tribes. But more importantly, it's really just about engaging that tribal voice. And I think that can be replicated in many other communities. We have a strong base of prevention science, but again, a lot of that is older. It's largely in white populations, two-family homes. And so whether it holds in 2024 or how it holds in 2024 in different community context is a place where we need to be very thoughtful as we're thinking about implementation and getting really feedback and information and buy-in from folks in communities to really understand who are those gatekeepers, who are the community anchors, the others that are going to make those programs successful and make sure that they are resonant to the populations that are being served.
Thank you, Captain Jones. I'll now turn the floor back to Dr. Everett.
Thank you, Brandon. Well, in closing, I want to thank all of our panelists. Each of you were so informative and really, really gave us a lot to think about. I also want to thank AI Media Captioning Service, who has been providing services throughout this, our closed captioning services throughout today's webinar. Our behind-the-scenes staff at TFAH, who've done an enormous amount of work to get us through today, and to each of you, the participants who listened, asked questions, and have really made the point of us being together worth it. Clearly, this is an important issue, and we will continue to pay attention to this and address this with policymakers, and hopefully reverse these crises. Recording along with the slides and additional resources will be available on tfa.org in the coming days. Thank you again for joining us, and have a wonderful rest of your week.